Hello, my name is Heather Blair. This is my PowerPoint presentation of my systematic review. Is there evidence-based research that evaluates the effectiveness of the current recommendation that the first oral health visit occur 6 months after the eruption of the first tooth or by age 1? This presentation is for my Master's of Public Health thesis for Concordia University, August 2015. Many people, especially children, have an oral disease, dental caries. Dental caries affects 60 to 90% of children. In children ages 0 to 5, this form of dental caries is referred to as early childhood caries. Dental caries is the most common chronic infectious disease of childhood. It is 5 times more prevalent than asthma and 7 times more prevalent than hay fever. Early childhood caries is considered a serious public health problem in both developing and industrialized countries. It can have a long-term effect on those it touches. Children may experience dental pain, tooth loss, impaired growth, decreased weight gain, delayed speech, negative appearance and self-esteem, decreased school performance, school absences, and a negative quality of life. It could ultimately result in the potential for loss of life if untreated infection progresses, as in the case of Diamante Driver. Early childhood caries may predict future dental health, as the biggest predictor for future oral disease is a history of oral disease. In the general public and the health industry, there seems to be confusion regarding the age of the first preventive dental appointment. There are many reasons for this: lack of insurance or funding, oral health awareness of the parent or caregiver, no referral from the pediatrician, lack of access to care, or dentists not taking children under a certain age, and no transportation. Many professional organizations recommend the first dental visit at age 1 or 6 months after the eruption of the first tooth. These include the American Dental Association, the American Academy of Pediatrics Dentistry, and the American Academy of Pediatrics. The review of this proposal looks at the costs associated with early childhood caries, the risk factors, the parental influence, and the barriers to care. The goal of my systematic review was to provide a summary of the evidence-based research articles that evaluate the current recommendation that the first oral health visit occur 6 months after the eruption of the first tooth or by age 1. This systematic review was conducted in a manner to determine whether there is an oral health benefit to children attending early preventive dental visits. A comprehensive literature search was conducted. The inclusion-exclusion criteria was as follows. The inclusion criteria was a population of children under age 8, English language articles, free full-text articles, peer review study articles, articles written between the years 2000 and 2015, and human studies. The exclusion criteria were articles in other languages or written prior to the year 2000. The databases that were searched included Academic Search Premier, Sinhom, PubMed, EBSCO, the American Dental Association, the American Academy of Pediatric Dentistry, and the American Academy of Pediatrics. There were 8 articles that were chosen for inclusion, 4 quantitative studies and 4 qualitative studies. There were not any randomized control trials for inclusion. Each article that was included was scored based on the quality of the article that reviewed the problem that was addressed, the effects that were measured in the study, the effects to minimize bias, and the recognition of the limitations within the study. On a 6-point scale, all of the articles selected for inclusion scored 3 or above. All of the articles addressed the oral health of children. The theme that was consistent among the articles was that children that were identified as high risk showed the greatest benefit from early preventative dental visits. There was a correlation noted between children that had more preventative visits and the likelihood of having higher subsequent preventative visits. In reviewing the monetary costs associated with dental care, those children that had early preventative dental care had significantly lower non-preventative dental visits and expenditures for care such as emergent or restorative. There were many references that noted barriers to care such as insurance-related problems, limited dental services for children under 3 years old, lack of emphasis on preventative dental care, lack of referral for dental care, perceived poor quality of some dental practices, poor care coordination, insufficient culturally appropriate care, and parental oral health literacy. There were also many mentions that made reference to the increased difficulty in accessing care for minority populations. There were several limitations. The first and most significant was the novice experience of the principal investigator. There may have been search terms that were inadvertently excluded from the study that should have been included, which could affect the reliability of the study. The small sample size also could be a factor. There were only 8 articles that were used, which may have an impact on the reliability, the ability for generalization of the data, and the validity of the information. There were articles that were excluded due to cost alone, as the inclusion criteria specifically stated free full-text articles. All the articles cautioned about their results not being used for generalization of their information. There was also bias to be noted, as there may have been interviewer bias. With only one reviewer, there is the potential for personal bias. Also, with the article self-selection. Some of the qualitative articles mention that some parents or caregivers may have opted out of participation because of their lack of value for oral health care, not allowing their opinion to be heard. And, as mentioned earlier, the general lack of research on this topic. Interestingly, the American Dental Association, the American Academy of Pediatrics, and the American Academy of Pediatric Dentistry all have position statements that support the recommendation of the first preventative dental appointment occurring 6 months after the eruption of the first tooth or at age 1. However, it is difficult to find evidence-based research that supports this recommendation. Due to the limited amount of research that has been conducted and published on this topic, the primary recommendation of this review is to conduct more research on whether there is evidence to support the benefits both to the child and cost effectiveness of this early preventative dental visit. In a review written by Hashim, Nayar, and Staffron, there are several recommended steps to be considered during the age 1 exam, which may include the clinical exam, anticipatory guidance, and establishment of a dental home. However, it suggests that there is a critical time for the window of infectivity, and anticipatory guidance and maternal counseling may be very beneficial for reinforcing the prevention of oral disease. In all the research that was done on the importance of this visit, there was not a consensus on how the age 1 visit was actually done. Therefore, it is recommended that further studies be conducted on how the visit is being handled. For instance, who is actually seeing the child? Is it the dental assistant, the dental hygienist, the dentist? And what is being done or discussed at the appointment? Is an exam being done? If so, how is it being done? Is it a knee-to-knee exam? Is it on the parent? Is nutrition being discussed? Bacterial transmission from caregiver to child? Home care? Fluoride exposure? Bottle versus sippy cup? The research showed for the children fortunate to have this exam that the care received could vary depending on provider or location. Another recommendation for the study could be the correlation between attitudes toward dental care from parents or caregivers and the impact that it has on their seeking dental care for their children. There have been some mentions of this in articles, but not a study based on the relationship. For some parents, they could have had a negative dental experience themselves that may influence their seeking dental care for their child, or there could be cultural differences in an area so large that they feel like their options are limited, or they may not have knowledge regarding how oral health may impact the growth of a child both physically and mentally. As previously discussed, this is an area in which evidence-based research is lacking. A researcher interested in oral health care and children could have many possible avenues to help address whether or not the age 1 dental visit has statistically significant benefits and how confounding factors may further influence the oral health of a child.